Yeah, so building off that last session, which was really interesting, we're going to talk now about building capacity and infrastructure across the network. So we're going to have 4 panelists. Each one will give us about 3 to 5 minutes of some prepared remarks, and I think one of our panelists will have a slide, and that should leave us at least half an hour for some questions that I can pose and that you guys from the audience can also pose to our panelists. So I'll just quickly introduce the 4 panelists, and then we'll get going. They're all here in person, which is wonderful. So the first is Dr. Angela Crawley, who I thought I had a lot of hats until I read the bio of Angela. She's a senior scientist in chronic disease program at the Ottawa Hospital Research Institute and also an associate professor in the Department of Biochemistry, Microbiology, and Immunology at the University of Ottawa and an adjunct professor in the Department of Biology at Carleton University. Her research specializes in the study of impaired immune responses in chronic viral hepatitis and metabolic liver disease, aiming to identify immune restorative targets. Dr. Crawley also serves as the biobank director for the COVARNet, where her expertise in T-cell biology and viral infections, as well as her experience in building research capacity through innovative national biobanking practices, played an integral role and is going to be, I think, very insightful for this panel. Mayred Whalen, you met yesterday. She's a health and geography, clinical disease, epidemiology professional with a diverse range of experience working on public health projects, and she, as you may recall, is the co-lead of the Sero Tracker project. Dr. Laurie Beach has been given a detention and will stay again for the second panel in a row. As you recall, she's a clinical biochemist and head of chemistry at IWK Health in Halifax, Nova Scotia. And then to fill out our panel, Dr. Sheila O'Brien, who you also met on the first day of this HemaNet conference. She has been at the head of epidemiology and surveillance at the Canadian Blood Services for over 20 years. So lots of experience here, and she's also an adjunct professor in the School of Epidemiology and Public Health at the University of Ottawa. Okay, so we'll jump right in, and I guess we'll go in the same order. So I'd ask Dr. Crawley to lead off first with your 3 to 5 minutes of your remarks on this topic.
Thanks very much. Thanks very much for your attention. I get that we're the last session of this meeting, and so I've kind of framed some of my comments in that context. So thanks again to HemaNet for the invitation of both the biobank members, Ray and I, as well as Marc-André, to be panelists, and we've been happy to be in this role with you since March when we met first time last year. So I want to tell you about the Canadian Biobank and Data Alliance, which is an initiative that sprang from the COVARNet Biobank. And so if you're not familiar with COVARNet, take a look at their website, but it's a very large network sponsored by CIHR since April 2021, composed of 9 or 10 research pillars, as well as these initiatives that support them, including the biobank. And so what we've done is spun out this alliance, and I'd like to tell you a little bit about that today. Next slide, please. Okay, so this is our mission statement to rapidly, coordinate access to resources across multiple Canadian sites for both an emergency and, of course, to grow in the future. And that's really what the CBDA is going to be all about. So we have evolved from our coronavirus initiative, and then we plan to pivot forward. So going forward to the next slide, we have a number of partners that to offer what we call a boutique approach. Many of these partners are within the COVARNet network and include other groups such as the Level 3 Facility Consortium Cable, Wastewater Surveillance, the Surface Sampling Cube, Indigenous group, which I'll talk about a bit more, our modelers and sequencers through Cameo, SimNet for modeling. And then we have external partners that is going to be a growing list, of course, with Popcorn, Long COVID Web, and of course HemaNet we feature as one of those partners. So next slide, please. So that was to demonstrate sort of like the capacity and the connection that we have to research scientists. We've also, laid out our vision and what has motivated us to start firstly with the biobank and then leverage this towards the CBDA. So I encourage you to take a look at this white paper publication, sort of set up the need that was in Canada for research biobanking nationally, what we've done and where we plan to go. And so that'll kind of catch you up to speed. We can move forward to learn a bit more about the CBDA. So it's a federated biobank system of research sites. These are the partners that we have currently across the country, and it really is meant to preserve their autonomy as stewards of their data and specimens for which they are responsible, but to also offer, open, fair, and rapid sharing of these materials and data. And this can happen with researchers in public health, and I'll tell you the tools. So you go forward as a quick list on the next slide of who these members are. So this is just a brief kind of list of it's growing. And we've met over 6 times in the past year. And so we're looking to formalize this, this alliance as we go forward. So what we've set up, Ray has already kind of told you going forward on the next slide is, we aim to have excellent practices, excellent standardization. So if you just keep clicking, you'll see that we're getting guidance from this CEDARnet, which offers a lot of guidance for SOPs and so on for biobankers. But if you really want to get international recognition, then you go through these ISPR guidelines and get your ISO status, which is we're in the throes to do. And we will be promoting the use of these across our members so that we can harmonize our practices. So if you go forward to the next bit, we've also reminded you or told you about the tools that we've pre-established. So this Universal Data Biological Materials Transfer, our UDB MTA, allows for and is in active use to share readily within days of an interaction between scientists to share their data and materials. And we have templated this and used it to encourage exchange between government and researchers, as well as with industry. So we want to continue to grow this sophistication. And of course, the research ethics allows us to sample all kinds of different specimens from blood, urine, and so on, bone marrow, et cetera. So it's very broad, usable right away. We have a metabase, which is very, very novel for ingesting information from our partner biobank sites, no matter what their system is. So this is really revolutionizing by using like a library system, essentially. Like we are the central catalog, and these are our branches, if you want to think about it like that. But that library doesn't actually have to give you their book if they don't want to. So moving on forward, I know 13 seconds is not enough, but I really need to make this point about engagement. We've talked about it a lot. We have a very serious collaboration with this group CEDAR in Covarnet to learn about the challenges of doing research when it involves data and specimens with our Indigenous peoples. This is hugely important, and it tells you that our mission as the Alliance is one of equity, diversity, and inclusion and indigeneity, and we don't assume that we will practice this. Okay, we lead with that mission statement, that we lead with equity and diversity and inclusion on the front of our minds. I think I just want to really make sure that we emphasize that with what we do. So there's OCAP training. If you don't have it, go get it. It's only $200. Just wrapping up, I think there's just like a couple of slides left. Yeah, so, I think you can all appreciate that biobanking is beyond freezers, and we can appreciate that here. There's a lot to be considered. It really is. Someone has told me before, it's a living and evolving, growing entity, adapting, innovating all of the time. We really need to talk about that to policymakers to make sure that they understand and appreciate that. So I'll close out with the next bit. Oh yeah, this is like the common language that we have. This is why we're all here. We all understand each other. You can make these word diagrams. But the last slide is to show a point that's been coming up. And I didn't know if I should use a Venn diagram or a puzzle or a mosaic, as I've seen in many slides in the last little while. But it is imperative that as each of these entities, public health, HemaNet, entities like ours, the Alliance, that we strategize together so that we understand where the limitations are of our work and our capacity so that the other can pick it up. And so that's kind of what the Venn is supposed to be using our color schemes. But we're a willing partner in that. So that's all I have to say. Thanks.
Thank you. Mayor?
Hey, hi everyone. I don't have any slides, so you're just going to have to listen to me for the next 5 minutes. Really, I think I'm joining this panel to talk on the SaroTracker experience and the infrastructure side of the network and how this really looks, and also speak a little bit to the data sharing and protocols working group for HeyManet. But over the course of the meeting, we've really heard repeatedly from everyone that there's a lot of challenges in data, and it's also super important from start to finish. There's data sharing, data linkage, data management and structure, getting the data from the labs into a usable format where it can be modeled, all of that. So I think it's very easy to look at that and go, wow, that's a absolute behemoth of work. That's crazy. How are we going to start? So I actually want to bring a concept to the discussion that we use quite frequently at SaroTracker, which we've borrowed from tech startup groups, which is the concept of an MVP, or a minimum viable product, not most valuable player, although I think we are all most valuable players. But the concept of an MVP, or a minimum viable product, is really switching your thinking a little bit and asking yourself, what is the smallest possible version of what we're doing that we would consider a win or successful? So when we think about HeyManet, what's the smallest thing we could start with that would not only allow us to bring value to Canada, be happy with an outcome as a network, and effectively test our assumption that we all have as a group, which is that serosurveillance is valuable. And I've been really thinking about this concept, especially in the context of colleagues at FACT this morning, really setting the tone of, okay, we're in a resource-limited scenario. We all want to make this happen. How are we going to make it happen? It's really the thought of starting small, and the advantage in that way of thinking is that it gets the ball rolling, the snowball rolling, if you will, given the weather. And then you can add pack along the way with expertise, and I think that's a mindset at SaroTracker that allowed us to be very nimble, really agile, move quickly, be comfortable. If we're going to put something out there, we're going to try it out. It's maybe not perfect right now, but we're going to learn through trial and error, learn through fire, and then that way we don't spend all of this effort putting together something that we think is perfect, putting it into practice after years of effort, and it just not working. So I suppose that's one thing I'd love to hear from the panel and the group is, how can we challenge ourselves? What is our minimum viable product? What's the smallest version of HeyManet that we could build, and what does that look like? The second thing I wanted to speak about is reflecting on a little bit of the work SaroTracker did with WHO and our Unity collaboration. We were working directly with all of the regional offices supporting these low middle income countries in the Unity studies synthesis that needed or were looking for support. And a lot of the reflections from that, I think, are really not that different from HeyManet and a lot of the problems we face in Canada. Number one, low resources, not a lot of time. The folks running these studies, we just heard from the lab panel, are doing way too much already. They have so much on their hands. If we wanted to implement some kind of direct data submission portal, asking them to then sit down and spend 2 to 3 hours to try and figure out the data template that we've put together, it's just not going to happen unless it's mandatory. That's really tough. We did this with WHO, as we had a really prototype version of a data submission template, and we ended up coordinating with all of them to correct it and fill it out. And what was most efficient for us is just to have them send us their protocol and their data, anonymized, and then we do it for them. But there's got to be a better way. Can we automate that? A lot of remarks on putting together a really plug-and-play incentivized data submission where, okay, you've submitted your data, and now we've coded and built these analysis tools to provide some basic analysis skills. That's another thing I've heard a lot over the meeting, is there's a lack of capacity in modeling, a lack of capacity in sophisticated analysis. How can we build a tool that helps fill some of those gaps beyond just trying to implement a new stream of MPH program, which would be really cool, but a lot of work. And lastly is just a brief comment. Thinking about SaroTracker and how in a training capacity mindset is really kind of a use case on the power of students. I think. So the story of SaroTracker is we were really, I'm running out of time, I have about 20 seconds of this, really a group of renegade grad students that came together with a dream. And, that's amazing. And you know what, we had the time, we had the flexibility, we had the drive, and we were able to come together and make it happen in a really short amount of time with the support of CITF, almost acting as kind of an incubator for the group, and just reflecting on how I think that kind of approach can have a huge amount of value for Haymanet as a network, and how we can really foster that kind of momentum and movement going forward in valuing students and really up-and-coming newcomers with big ideas. So that's all I have to say.
Thank you very much, Mary. I think it's a good plea at the end. It was well spoken. Lori, over to you, please.
I really like your idea of the minimum viable product. So, yeah. In terms of thinking about building capacity and infrastructure, my thoughts were maybe a little less data-driven and a little bit more people-driven, and that's just from our experience. If, for example, I were to say that we're going to do some pulling of samples even, banking of samples, shipping of samples, and or testing of anything in my area of the world, it does feel like it needs to come out of the clinical laboratory because those individuals are dedicated for the clinical work. So for me, part of building capacity and building infrastructure is very much around benches and water systems and like if we're actually going to do testing and freezers, or figuring out where those partnerships are in order to make it happen. But one of the things that I think clinical labs are going to continue to struggle with, we know we're going to continue to struggle with, is the HHR. And the reality that there's no one to hire. So even if I could get approval to hire people, there's no one to hire. So that's sort of the situation that we're finding ourselves in. I love the idea of automating as much as we possibly can. Even in terms of the data submission, I will fully admit that my data was slow to arrive because I had to manually put it in. So yeah, if there's ways that we can, leverage technology that we already use, for example, in the clinical laboratory with interfaces, with HL7, with, tools that we already have in our toolbox so that we can make it automated, let's do that. And I think that is going to go a long way to bridging the gap between what is ideal and what is possible, and then also making whatever it is we choose to do something that we can sustain in the long term as well. So I'll be short.
Great, thank you very much. And finally, Sheila, over to you, please.
Yeah, I have some slides.
Do you want the clicker or do you want to do the
Oh, sure.
I'll voice it.
I want control here.
Next slide.
Should have done that. Oh, thank you very much for this opportunity. Why doesn't it move for me?
Now they've... Yeah.
Okay, there we are. Okay. Yeah, I thought I would like to tell you about some work that we've been doing over the last year. So this group that you see on the are the list of co-authors on a paper that we've recently submitted. We came together at the COVID meeting last year in March for the purpose of evaluating what we've learned, what we could have done better over the pandemic, but specifically this group, because these are the principal investigators and key people in seroprevalence studies over the course of the pandemic. So it was really something coming from the people who were actively doing the work over the course of what seemed like an eternity. Tim went through which the studies were at the beginning, and I'll just remind you a little bit about them because I think it's really, really important. The ones shown in red are the national seroprevalence studies, and the ones in black are regional. So ABC was a market research cohort that was leveraged for to use dried blood spots and questionnaire at multiple time points. CanPath is a cohort that in normal times is studying chronic disease and cancer. Statistics Canada, that was a new study, but it was using the methodology that they use for their other studies. And Canadian Blood Services, we leveraged leftover blood samples, which are normally discarded. And then the other regional studies, for the most part, were using residual blood samples from patients which they had experience with. So the group have come up with 9 recommendations, which I'm not going through now. But what I will highlight is that many of the things that we came up with are things that we have talked about today. So things like barriers in data linkage, the issues with data sharing and how that needs to change. And issues with testing capacity and assay development. But I have 3 things that I particularly wanted to mention or to call out. So I think really what is critical to the pandemic response will be having robust routine serosurveillance in place. And in addition to that, systems and studies that can transition. So that's how we managed to do things over the pandemic. We would never have got anything in place if we had to design things from the ground up and go and find new participants for the studies or blood donors. It was all because we just took what was there and then transitioned it. And then when it's no longer needed, you transition back. So I think that is really key. The other, I think that fostering relationships between government and non-government organizations was also absolutely critical. I would have to say that it is unprecedented, the amount of collaboration between universities, between biopharma, and between other non-government organizations that we normally never think about. So, for example, the Blood Service, also the market research cohort. Those were it was a very unique experience. But we have to be really careful, be really cognizant of not letting go of it as we kind of return to our other activities. And then finally, something that really jumped out to me in the course of discussion about where we should go was the difference between smaller jurisdictions and larger jurisdictions. So smaller provinces have to do pretty much all the same things in a pandemic as a big province, but the workload doesn't shrink proportional with the population, of course, and there's a very limited number of people who have to multitask to get things done, and they were particularly left exhausted by the pandemic. So when we come to talking about what should we, how should we develop capacity, I think we need to be thinking between small jurisdictions and large jurisdictions and how to make that equitable and workable. And that's what I would like to say.
Thank you. Wonderful. Well, thanks. An excellent set of opening remarks, and I think we've got the stage well set now. So I'd like to start out with a few questions, and then I'll invite people from the audience to come forward. So think about your questions perhaps as we get going. I kind of want to start with Mayred's MVP, so minimum viable product. So I think, for those of you who aren't aware of that framing, it's kind of part of an agile methodology where you don't try and get everything right the first time and then release it 2 years later, but you're trying to get the MVP, iterate, improve. But In my experience, one thing that's really critical about MVP is having a clear sense of purpose. What's the problem you're trying to solve? And what are the kind of attributes of success for that MVP? So maybe if I could ask each of the panelists just to reflect on, from your perspective, what is the most sort of important component of what you're doing in a national serosurveillance network, and what would be the one or two things you would want to make sure that that sort of minimal viable process or thing that you're going to do should what would be success for that? So maybe Mary, because you started us off, I'll let you start while others organize their thoughts.
Yeah, that's a really good question. And I think, that is one of the challenges for HeyManet is to all unify all of us together on, okay, what is the one big thing we want to start with? What would solve the problem? In my opinion, I coming from a very data perspective, is getting high quality data all together in the same place would be fantastic. Now that is a very small sentence for what is an absolutely really huge operation, but how can we boil that down? And I think in a lot of ways, it's possible we're already on the way to a minimum viable product through the work that's being done at COVARNet or the collaboration between BC CDC and CBS. That's a small scale version of what we're trying to do on a large scale. So I think possible we're on the way. I think maybe the question is how, as a network, can we unify to support that budding flower, if you will.
Great, okay, so makes sense. And you picked up on Sheetal's analogy. So we have this, it's that access to high quality data, whether it be centralized or maybe federated. And as you point out, we have some examples are already on the way. Okay, Sheila, do you want to go next? What's your thought?
Yeah, well, I think if I can relate it to our experience over the pandemic, I think that was what we did. We did what we could. I would have loved to have a great sampling mechanism where I could choose which samples I wanted to test and have full data on those samples. What we ended up doing was saying, okay, we got to get moving, and we got to get moving fast. We don't have any way of picking the samples, but we do pull them off the line from both of our two sites where we have testing. We put them we spun them down and put them in boxes. So if we wanted to get a random sample, I can take one box from the east and one box from the west, east, west, east, west, until I've got as many samples as I wanted to test. And it would work out as a pretty random sample, which it did. But it wasn't the ideal way of doing things. It's just you do what you have to do to get to the most important thing, which was to get samples into the lab and getting them tested. And it was the same thing with the management of the data. I would have loved to have done lots of really interesting analyses over the time, but we had to get a report out, and that was so you put that as your priority, and getting it into a template, getting the main things that people want to see. So that was basically anti-N positive initially, eventually got anti-S, but it was anti-N, proportion anti-N positive broken down by demographic variables. So that's what we did. But absolutely, you have to start with what can I do to get something out, and then now we're in a phase where I'm able to look at how can we do things better.
Great, okay, thank you, Sheila. So it's really for you is more the sampling and getting out of the kind of the samples and into the lab. Yeah,
Yes,
okay.
exactly, yeah.
Perfect. Angela.
Great. So I learned something new, minimum viable product. And translated into my language, that means the lowest hanging fruit. It's not that novel. Just kidding. But no, I think, so like the train was already out of the station, right? So the individual scientists were already carrying out their projects, at least in the academic research sphere. So they're collecting specimens like quickly with the money that they were able to get already. But for us as a biobank, the first thing we needed to do was to develop the tool to share, which is what we were all about. So although that seemed like a long ripening fruit, took a year, for us, that was the lowest hanging fruit. It was the first thing that we had needed to do. The scientists were carrying out the work, generating all the specimens, but it's nothing if you can't share them. And then using that tool. The moment we got it, We have been using it ever since. And so demonstrated use of an innovative tool to do exactly what you were asked to do, which was to share your resource. Now, the description of the resource, how was it collected, by who, where, how much, in what tube, yeah, dog's breakfast. But we will learn from that, right? We will learn from that. But without the tool to share, you're nowhere. And you're just operating on your silo. So for us, that was hugely important. That was the lowest hanging fruit. And we have demonstrated use. We have a lot of happy people who have their specimens and published within the month. So this is, for us, I think, is this concept of sharing so readily, so disruptive, but so important. For us, that was our minimal viable product. And it's been something that we can leverage towards revolutionizing the way in which we do research around this country and how we work better together. Oh, so there's my fruit.
Great, thank you. Lori, over to you.
When I was trying to frame that question in a way that I understood it, it was, what does success look like? Or to put it in a quality framework, what's the key performance indicator? Or how could I PDSA cycle this so that I could keep improving in an iterative process? What could be the outcomes that I would look at? And I think you could break that down into all of the individual components that I think are represented here around sampling, access, sharing, data. Where my brain went was, what is it going to mean to Canadians that we can actually show value add? And for me, that was, can we show either through a model disorder, for example, like keep going with SARS-CoV-2, and say in real time, can Canadians know what is the burden of X in a fully representative population? That sort of feels like where we're trying to go. And then if we can do that with a model that is limber enough to change and adjust, then I think we start to demonstrate value that might resonate with everyone, not just the people who care about it.
Great, okay, that sounds, so for you, it's about getting that inference or that understanding of disease burden and how do you, just making sure you can continue to improve on that.
Yeah.
Yep. Okay, great, thank you. So that was an excellent set of responses. I'd like to take us in a slightly different direction. So certainly for CITF, and I imagine for HEMANET, I'm thinking now, again, if we had another public health emergency in the future, there would probably need to be a balance or a combination of both serosurveillance, by that I mean systematic, repeated collection and analysis in an ongoing way, but with a sort of systematic process over time, and targeted studies, where you're really thinking about science, and you're really thinking, okay, there's a key unknown here I'm trying to address, a knowledge gap I'm trying to close. So from each of your perspectives, what are the differences in terms of infrastructure for one versus the other? Are there, from your perspective, and if so, what's your thinking about the relative weight or importance of those distinctions in how we essentially put together a pan-Canadian group that's thinking about preparing for what might be the next public health emergency in the space? Do you want to start and go back the other way? Is that okay?
You can try.
Put you on the spot? Thank you.
I think there's some continuity in terms of the need for specimens that would translate across whether it's the key research question versus the other. And having that continuity of access to specimens seems like the common thread. In terms of the nuts and bolts of who's going to do that research, I think that's where you let the researchers be the researchers and you let them do what they are awesome at. So
from your perspective, there's not a lot of distinction between the two in terms of what you're doing? Is that, might not just oversimplify, but?
I'm saying the specimen side of things, to me, seems like there's lots of overlap in terms of the how are we going to leverage who's going to actually answer a specific research question. That's where, from my perspective and my resourcing in my area, I would say I would seek strategic partnerships with specialists
I
in
see what
that
you're
area.
saying. Okay,
Yeah.
makes sense. Thank you.
try. So yeah, I mean, I see serosurveillance and intentional sampling as complementary and different, right? And necessarily so. So, you know, like, there's a, you know, a limitation to the population that you can have access to in serosurveillance. I think we've identified some of those limitations today in age and representativeness, perhaps. But certainly, so these are things that intentional banking can do through long-term care, through, you know, pediatric access that's a bit more. And then as also the type of work that's done through research questions require a certain type of specimen that is rather labor intensive and would defy your model of cost effectiveness. And so that's where, you know, intentional research costs more money in some ways, but funded in the way that I'm proposing through this system is cheaper than not having this ability to share. And so I think there's definitely complementarity there, so we can fill some of the gaps that serosurveillance bears, but also go deeper. And so we have access through our research networks to the surge capacity, the experts in a given area, as you've alluded to, right? So I think and there's a need for that to complement some of the sort of first layer of information that serosurveillance may be able to get, and then we can kind of go a little bit deeper. And this, I would end in also saying that the sample types also, so you know, bone marrow and CSF, like our ethics allows for the access to a broad array of sample types that wouldn't necessarily be captured in the surveillance approach. Thanks.
Thank you. Sheila?
Well, I think there are situations where the routine might inform the targeted. So
Complementary.
yes, yes. So for example, if you are doing routine surveillance of infections carried by insects, so for example, tick-borne infections or mosquito-borne infections, and you start to see that there is an increase in activity in a region, that the first thing that you would think is, well, okay, there's this infection that I'm screening for, but maybe there are others. And so that would inform doing surveillance in a targeted area of certain other infections that could be there that didn't used to be there. So we are facing that now as infections are moving further north from the States. So I think that we would, the challenge is really to recognize how the surveillance is informing where you need to target.
Great. Thank you, Sheila. Ed?
Yeah, so from the SaraTracker perspective, it's a bit unique for us in the sense that our database was entirely a systematic review of publicly available papers. And the question was, relating to this one, really, how do you mediate that emergency, high, intense effort, public health versus routine surveillance? I guess an example for us is when we first started extracting papers, we extracted every single estimate from every single subgroup from every single paper that was coming through. That was very intense. And at this point, we have over 4,000 studies in our database. If we had done that for all of those studies the whole time, we wouldn't be here. We'd still be coding, actually, and working through those. So at some point, we had to make a call where we needed to streamline what we did extract, and made the call that what was being asked of us and what was producing the most impactful results was understanding seroprevalence in the general population and where those immune gaps still were, which meant we stopped extracting extra subgroups for special populations like healthcare workers, pregnant and parturient women. But I think what's helpful when we did make that call to streamline is that we still had our protocol to fall back on, and we organized our database in such a way that while our extractors were going through, they'd label which subgroups were where and what studies had what, so that if you know, the Prime Minister of Canada walked through our door and said, needed analysis on healthcare workers now, we'd be able to quickly filter through our database, identify which studies had that data available, extract them really quickly, and produce it. So I think the lesson here is while continuing a routine baseline level surveillance, building in those nets kind of to catch you, if you will, to fall back on, so that should that scenario come up, you're confident in your team's ability to be able to bounce back.
Makes sense. And I was thinking, about for example, Johns Hopkins dashboard where they scrape data from all over the place. I mean, you must have thought about that possibility of going and trying to scrape serosurveillance that wasn't published but was available. Like,
Oh yeah, we did that. Yeah, so we captured published articles, preprints, institutional reports, media articles, tweets. There was a while in the beginning of the pandemic where we actually coded into our database a tweet from Governor Cuomo, who tweeted seroprevalence results, and we put it in our database, and it was really frustrating, but we did it. And so we took a similar approach. We tried to be as comprehensive as possible, and it was really intense, but we have it, so.
So you were combining
We
them,
were,
surveillance
yeah.
results, other, great.
Yes,
agreement,
yeah,
okay.
just for seroprevalence,
Yeah,
but,
yeah.
and we had other dashboards to fill in the gaps for other information, but yeah.
Great,
Yeah.
great, okay. All right, so if people have questions, please come up, otherwise I'll keep asking, you'll have to listen to me. Oh, okay.
It's actually more of a comment. I think, how the routine informs the targeted. I think Marc-Andre brought up a good point about, can I quantify something? If I can quantify something, can I use your antibodies as an interventional product, right? Can I then do an interventional study and a case control study where I use what I've learned on the surveillance side to tell the clinician what the characteristics of that convalescent plasma is, or what the characteristics of that monoclonal antibody is in terms of protective nature. The other one is understanding the serology to do things like vaccine effectiveness studies. So looking at who got sick, who didn't, and what the seroprevalence rate is might tell you where to set your endpoints for things like VE studies. Do I set it at infection, or do I set it at another clinical endpoint such as symptomatic disease? So those are two things where having a good seroprevalence network and understanding the test characteristics and whether I can quantify something and how much characterization can I give to that specimen or that sample of that product really supports other direct interventions that may have really important population impacts later on.
Great, thank you. Does that trigger any thoughts from our panelists? Wasn't exactly, it was a comment, but any perspectives?
Yeah, just thinking, like, if we're going to do that too, I think in our organization, we need to have more clinicians working alongside the research scientists as well, because, I can't make that call, right? So we need to have, among the best ID docs and such to be sitting at the strategy table with us, to assist in making those delineations that are meaningful to their practice, right? So we know our lower detection limits and acceptable standards and la-di-da variants, and but you need to have that clinical translation more actively in everything that we do.
Good point, and maybe I'll pick up on that for a more general question. I think the point was made about, I think maybe the point about mobilizing students or engaging students, and then I think Sheila, you were the one that spoke about NGOs and other groups. So the question to the panelists then is, I guess it's kind of twofold, maybe a bit based on what we just, the point that was just raised. Are there gaps that you're aware of in terms of stakeholders or expertise that don't seem to be at the table, as it were? And or are there other groups that we could sort of better engage to mobilize? And how would that look in what you're trying to accomplish? You want to start?
Can I
tell you
talk
when to start.
again?
Go right ahead.
Yeah. Just I'll talk all night. But two things that I thought about would have come up is to do with the contracts. So having the legalese or at the table to help. I mean, I know they're expensive, but I think they're so deeply needed in order to, for us to overcome some of the contractual challenges that we have, and also the ability to go across provinces and all that. So I think we need to invest in some contract help. And the second was the communications piece, that we need to be, as scientists, even better communicators, to tell the public more about like the value of what we're doing. I don't think they understand. If you know, whenever I tell my family this is what we do, and they say, oh, that sounds really good. Like, how can I give blood? Or, you know, I think we need to do a better job of that
Excellent point.
by some professional.
Excellent points. I can say, as being the victim of over 70 data sharing agreements, legal is very critical. I think it also helps to clarify and break down barriers to information blocking, because you can often get a much clearer line of what's doable and what's not. Anybody else on the thought of, yeah, Sheila, go ahead,
I
please.
have a thought. One of the things that I have found difficult to get at is understanding the perspectives and the needs of public health at the level of the public health unit or the regional health authority. We really kind of played to national and provincial serial prevalence. In the last couple of years, we could have done it much smaller units, and I haven't seen that group at the table, and it's hard to know what would they need, what would they have liked from us if we'd have been having those conversations. So I think one of the things for the future that we need to do is to engage more at where things actually happen. Like, some decisions are made at the public health unit level, and there's really no point in talking at the provincial level. That's really where you need to be thinking and targeting what you're producing, the data that you're producing.
Thanks, Sheila. Anybody else want to comment? Okay. I will go to my next question then, which is also sort of triggered by the comment on automation, which means taking a process you're doing manually and trying to make it more efficient by bringing in usually something digital, not always, but sometimes, or mechanical. There's another view on that, which is transformation, which is you actually don't just try and automate the process, you try and figure out, like, what's the objective, and is there a better way to do this, maybe? So maybe from each of your perspectives, what is, you know, you don't necessarily connect it to your MVP, but, you know, in terms of a process that's really critical for what you do in your piece of this infrastructure, what would you love to automate or transform? Thinking that these are things that could become applied research problems, or if funds were available, you know, areas to address. So, Mary, do you want to start?
Yeah, I can start with that. And we've kind of hinted at we've done quite a bit of work trying to automate parts of our process to make our own lives easier doing systematic reviews. So I guess the easy answer to that would be automating systematic reviews, or the aspects of it that are really just, okay, we've got a set of rules, we've got a protocol, can we automate this? We've tried, we automated the majority of our risk of bias and critical appraisal process, which we validated against our own extractors, so we did that. We're currently exploring, as Harriet mentioned on her panel on day one, in the early stages of seeing if we can test our systematic review process in AI versus our own, and see if that's comparable and possible. And I think that would unlock a huge amount of opportunities in being able to run this kind of literature scrape quickly and easily. Just really all we did at SaroTrack at the end of the day is unify and centralize data. And even just doing that was really helpful for policymakers. It allowed a huge shortage in time at the policymaking end. Say you were a policymaker or a scientist who was really interested in seroprevalence in kids in Canada. You could hop on the SeroTracker website, add a filter for seroprevalence in kids. You can even add it for an ELISA assay instead of a chemiluminescent assay in Canada. It reduced our database to like 20 studies out of our 4,000 that meet your criteria. Your literature review's done for your paper of comparable studies or whatever. So that was a tool that was, we unanticipated. We didn't realize it would be as helpful as it was, producing that summary of literature reports. So I mean, I think there's huge potential in making this kind of thing more accessible and easier in a living review style that could be repeated. Because the traditional style is you publish a literature review or meta-analysis, and instantly it's out of date. The second you run your search, the day after, it's out of date. But being able to do that in a repeated, streamlined process, I think opens a lot of doors and saves a lot of time for really good work to be done elsewhere, and I think it's absolutely possible.
Great point. So Zero Tracker itself kind of was an automation process from the outside in a way.
You from the outside.
And within it, there was automation and some mechanical turking, but really,
Yeah.
yeah, for the user's perspective, it was.
Yeah, we used last idea, because I've just thought of it. We used machine learning as well to help us streamline our abstract review process, to kind of give tools to our screeners to help them go through it quicker, and we found that it did, which was good. So I think there's just a lot to be done, yeah.
Great. Sheila?
Yeah, I don't know about automated, but within Canadian Blood Services, I think the thing that we really have identified as something that could be done in like a smoother transition is the approval process for our donor research. So the pandemic really highlighted how difficult it was to go through our whole process. We go through legal and we go through various steps. You know, it goes through IT and then it goes to research ethics, and then, you know, it takes a long time. So we want to set up a donor research program that will have a lot of those things pre-approved. So some of the consent aspects, some of the legal aspects will already be in place, so that, and it will have its own research ethics application form, so that we can drive things through faster. So I guess you know, it's a very practical example of something that we've thought of that we can do, that the pandemic made us think of.
Great. Process improvement, I think that fits within the theme.
So for us, with the Biobank and Data Alliances, that you know, we've already got our contractual sharing process for academics and sometimes industry and government set up, and research ethics as well. So the other part is to make sure that it can happen, all of it can happen quickly, because you need to be able to access the resource. So automated for us would be when we're bringing in the data from all of the partnering biobanks, that be populated to the dashboard quickly, so that your catalog is up to date. So when users come in to our dashboard, they can see what our collection includes, and that this be represented visually, you know, how many specimens has the country collected from here to there. Of course, it's all de-identified. This is just high-level information. So, you know, and we plan to meet this need by having regular uploads with our partners. The expectation is, if you're with us for the, you know, that means you need to meet these upload deadlines, and then populate the dashboard, so that that will facilitate the speed of the access. Because if you wait too long to tell us what your inventory is, then we can't share it for you quickly or make it available to the research community. So that's like automation. And the transformation piece is, you know, to report this. We can learn from the BQC 19, for example. They had $10 million, so they did this very well. They reported to the community quite quickly what they had. They carried out webinars, they had reports. They would tell us how much of this data had been characterized by genomics, serology, you know, these types of things, how many of them had cell numbers. So there was a sense of accountability of what have you done with your resource. And it just makes it all the more attractive to be accessed by the community. So that's how I would automate and transform.
If I could just ask a quick follow-up question, because I noticed on one of your slides, you had, for data submission, you had an API or an application
Yeah.
programming interface, so it meant that people could automate data submission. What proportion of your sort of partners use that as opposed to a manual upload?
Yeah, so the reason we haven't got numbers on how many are doing this yet, but we had to put that in, because we can't impose on our partners what system they need to use to maintain you know, some people, if you're a small, humble biobank at Dalhousie University, you're operating off of Excel.
Yeah, yeah.
If you are from, you know, UHN, you have some other thing, or maybe someone's using REDCap or a TIM. So we can't take in all that language, so you have to have the API. But according to Amy Shu, she says relatively easy for most of these systems, even if she just explored one with BC Biobank. And she said, oh yeah, actually it's not that hard to it's basically, as Ray said, it's a translation system. And she said it's actually not that difficult to have her software engineer program this translation module and then ingest the data. And we're talking about all the data. It's just the data related to the specimen, so it's not all the data.
Yeah, yeah, but you do need that expertise in-house, probably, somebody who can create that interface for you.
Yes,
Yeah, yeah.
yes. So that software engineer is highly valued
Yes.
and expensive,
Great, thank you.
but very good.
Where do you go?
It's going to be a little different again, because I'm still thinking about the level of actually, if I'm generating results, the key stressor being the human beings to actually do that. And things that, whether we have a few labs or a centralized lab, like where's there room for, again, automating or transforming. One of the areas that I think we could make some really potentially unique strides, especially as a network of laboratories, would be in the way that we automate or transform how we monitor and build quality into what we're going to do, so that we're really, really confident in the results that we're generating, because we have a common framework for what a quality result is. And there's some really interesting tools that are out there that I think could be leveraged in new and more automated ways, so that you wouldn't have to have someone who's already got 12 other things on their plate, like specifically looking at that one item of quality. So I think there's some transformative work that could happen there. And I'm just really plussed about the idea of having more and more automated ways of actually getting the data where it needs to go.
Yeah, that's a really interesting comment on quality. It's because certainly the surveillance concept, largely people have often thought about evaluation, which happens periodically, but are now more and more moving not only to evaluation periodically, but to this more almost ongoing monitoring and assessment of quality and performance in a way that, allows you to sort of monitor operations. Is there a value to doing that at a kind of faster cycle, do you think? Maybe give us a quick example of what a quality thing you would pick up by that fast monitoring or more.
Yeah, so I mean, this is definitely coming from like my clinical lab hat, where we would never perform without doing that ongoing quality monitoring. And that's just not running QC, but it's all of the other quality assurance. It's what do we know about our procurement process, our inventory, our how our equipment is being maintained. It's sort of taking it out of that research and almost clinical, right? In like moving it in that direction. And so I think we can learn from the clinical labs in terms of how we can make sure that we're still maintaining that level of whether you want to go for something like ISO 15189 or some other international standard that we're happy with. Our experience right now is that we have layers and layers of layers of, well, it seemed like a good idea at the time, so we added this thing, and now we feel like we have to maintain it, and it's really labor intensive. And it would be great to just take a step all the way back if you're building something from scratch and say, what is the most efficient, most automated way that we can have the same definition of quality in all of our network labs?
Great,
Yeah.
wonderful. Are you getting up for a question, Sarah? Oh, absolutely. I was about to close, but I would love to give you the last question. Go ahead.
Hey, it's not actually a question, but I did want to, just before you close, acknowledge Mayor and Rahul and Nick and Harriet, who joined me and a number of other colleagues on a panel at the Canadian Science Policy Conference about using Zero Tracker as an example of knowledge mobilization, synthesis, data visualization, and also came to speak to our Assistant Deputy Minister's table on science as an example of the same. And I want to just put that in the mix because it was never intended through the CITF investment to see this kind of product emerge. Maybe it was intended by Tim and Kate and David, I don't know. But I think I just want to really acknowledge that and also acknowledge the contribution of students and innovation in this space. And that has been a takeaway, I would say, for my thinking, and I just wanted to acknowledge that as part of the session today.
Great, thank you very much, Sarah. Excellent point to underline. And yeah, I think we had a great discussion. I want to thank all of our panelists really for the range of perspectives you brought to this problem or issue, I guess, and lots of I think good ideas about how we can move forward and get the MVP into a I guess proof of concept comes first, I think. So then
Version 0.
yeah, version alpha. Okay, all right. Thank you very much. And I think now. Yeah, thank you.